Hello everyone and welcome to my channel.
So let's study about lipid metabolism. Let's first study about digestion. So when you intake your food, it is first of all broken down by the lipases. The lipid present in your food, basically we're talking about lipid now. So the lipid present in your food is broken down by the lipases, and we have different types of lipases, right? So there is the one in your mouth, which is secreted by the salivary serous glands, and then we have stomach lipases, and then there's the one in your intestine. So these lipases, what they do is that they will break down the complex lipids into uh, your monoglycerides or diglycerides. So generally the mouth lipases present in your oral cavity, these are associated with digestion of medium chain fatty acids. So I will be using more of a short forms. Then the stomach lipases present over in your stomach, these help to break down the triglycerides into monoglycerides and diglyceride forms, and so does the intestinal ones as well. uh, okay, now after the lipid have been broken down into these fatty acid chain, triglycerides are also broken into these monoglycerides and triglycerides. So these forms, then these are packed up in a structure called mycel. And what does it has is basically, so we have those vitamins or fat. So mycel, the coat is it consists of those fats and those fat soluble vitamins. These are present inside, and periphery are the hydrophilic ones. Okay, so these mycels, these then further, they are acted upon by bile. So these bile also help to further emulsify these fatty acids, so that these could form a better micelles. Okay, they help to emulsify the fats. Okay, and then these are taken up by your enterocytes. So this is basically, mycel is like a platform which helps in your absorption of the these fats into the into your enterocytes, intestine, right? Now we also have some pancreatic enzymes which can help in further, uh, you know, to form these cholesterol, fatty acids, and glyceride forms. Now, when they enter the enterocytes, two things happen. So we have these, as we said, we can have small, medium, and large chain fatty acids. Okay, so the small as well as medium chain fatty acids, these both can be easily taken up by the enterocytes. From the enterocytes, they go to the hepatic, basically via the portal vein, they will reach the liver, and then uh, these are sent into the systemic circulation, where they will bind with, they flow in your blood in a bound form. So these are mostly bound to albumin, and then they are sent off. But what about these large so these sorry so these large fatty acids, they cannot directly go into your systemic circulation. So these are also of course taken up by the enterocytes, but these are broken down into triglycerides and cholesterol ester forms. Now these are further modified. So for that we have the processes which, the first process it take is called activation. So activation of fatty acid, it takes place in the mitochondria. So here the fatty acids combine with coenzyme A, and they form acyl CoA. Acyl CoA is the form which is an activated form of of fatty acids. Okay, so this process takes place in mitochondria. Then we have monoglycerides, which combine with these acyl CoA and they form triglycerides. This process takes place in the endoplasmic reticulum. Then these triglycerides, they have their corresponding lipoproteins, that is ApoB48, and then what they form is your chylomicrons. So triglycerides get it coating, and what it forms is a chylomicron. Now these chylomicrons then they are sent into the lymph, and they can travel. So this process takes place in the Golgi apparatus of these cells. Okay, so I repeat. So we have mitochondria where fatty acids mm, become activated. This is called acyl CoA, which is the activated form in the endoplasmic reticulum. They form triglycerides, and then these triglycerides are packed into chylomicrons in your Golgi apparatus and sent to into the lymph. Okay, now let's talk about these chylomicrons and other lipoproteins. Okay, so we have thing called lipoprotein. So what exactly is this a what is this lipoprotein? Lipoprotein is it is a structure or a molecule which has a hydrophobic uh, core and a hydrophilic content are present in its shell. Okay, and these lipoproteins basically, so what do we have in the inside? The hydrophobic part consists of triglycerides and cholesterol esters, whereas the outer shell, it consists of phospholipases, and the we have those apolipoproteins. These are present in your outer shell. Now we have various kinds. So for the first one is HDL. So HDL is a high density lipoprotein. Then we have LDL, IDL, then very low density lipoprotein, and then we have chylomicrons. These are the 5 lipoproteins. Now as we go down these so the triglyceride levels are increasing. So I'll tell you the content. So these HDL, they consist mostly of phospholipids. So PL stands for phospholipids. I'm sorry, I think I got it wrong. So what does HDL? Basically, it has those phospholipids and other proteins are present. A little bit of it does also have some amount of cholesterol as well. So I'm just writing the most important chunk. Okay, so mostly HDL has phospholipids and the proteins. Then LDL, it has majority cholesterol. IDL has equal proportion of all of this. So it has the phospholipid, it has the protein component, it has cholesterols. Okay, so everything is there. Now VLDL, it has more of, okay, sorry, I am forgot. Okay, now VLDL, it has more of triglycerides and chylomicrons also. So here the content of triglycerides is more as compared to other cholesterols or proteins. Now from where does this HDL secreted off? So HDL is secreted by your GI cells, that is basically your enterocytes, and from liver. LDL is secreted from the peripheral tissue as well as liver. IDL, it is basically formed from this VLDL. VLDL helps to generate IDL. It is broken down into IDL. Now VLDL itself is formed in liver, and chylomicrons again in GIT, the enterocytes. Now, what does HDL do? Basically, it transfers these cholesterols or lipid content into, it will transfer it to liver, and this HDL is said to be the good cholesterol, because it is taking all that cholesterol lipids into the liver. So, okay. And then we have LDL. LDL is the bad cholesterol. Why? Because it will be taking all these cholesterol to periphery. So it is taking it to the peripheral tissue, and this process basically occurs with a thing called LDL receptor endocytosis. So all those cell surfaces which have these LDL receptors, so the LDL will go and bind to them, and via the endocytosis these get deposited in those tissues. Now IDL, as we said, that VLDL breaks to form IDL, and then IDL will take those triglycerides and cholesterol to liver. LDL takes the contents to the periphery, and then we have chylomicrons, which again takes it to the periphery. And also we have the broken remnants, which what we say, the remnants of chylomicron, those are taken to liver so that it can recycle it. Okay, so this is a bit about the various kinds of lipoproteins. Now these lipoproteins have a coating called apolipoproteins that is present on the outer shell, right? So what is the function of these? So we have basically, excuse my handwriting. So we have ApoE, then we have ApoA1, C2, ApoB48, and ApoB100. Okay, so ApoE is basically the one which takes the contents to the liver. So ApoE's function is just to take the contents to the liver. Now ApoA1, it helps to activate the enzyme LCAT. Okay, so this is present, LCAT is present in HDL. LCAT stands for lecithin cholesterol acyl transferase. Okay, so we have LCAT, which basically is helps to esterify. What is its function? Is that it helps to esterify the cholesterol which are present in HDL. Okay, so that it becomes densely packed. So ApoA1 will help to activate this enzyme so that it can esterify the cholesterols. So what does it do is it will cause cholesterol esterification in HDL. Okay, now then we have is ApoC2. So what this is a cofactor for lipoprotein lipase. What does this do is it will basically, uh, as the name suggests, so whatever your chylomicron, everything is there. So in presence of lipoprotein lipase, it will break down those contents to fatty acids and those chylomicron remnants, right? So it helps to break down those fatty tissues, right? Fatty and then to fatty acids and cholesterol remnants, etc. Okay, so that will help in breaking down, right? So that is the function of yes, ApoC2, which will act as a cofactor for lipoprotein lipases. Okay, then we have ApoB48. This helps in secretion of chylomicrons. So when your chylomicrons are secreted off from the GI enterocytes, you can say, so it has this coating of B48 present on it. B100 is present in your LDLs. So all those, uh, it helps in the endocytosis. So we talked about those LDL endocytosis, the receptor mediated endocytosis. So this B100 helps in that. Now EPO is present in all except LDL. So APO is present in all. So ApoA1 is, as we just said, it is mostly present in HDL. Then we have C2, which is present in chylomicrons, VLDL, as well as HDL. ApoB48 is present in chylomicrons and the remnants. And then we have LDL, IDL, and VLDL, which contains this B100. Okay. The next thing is about some enzymes. So the enzymes concerned with the digestion or breakdown of this lipids are, so first of all we have hepatic lipase. So what will this enzyme do? This will basically help to this is basically present in your liver, of course, as the name says, and this will help to break down the triglycerides in your IDL, intermediate density lipoproteins. Then the second one is hormone sensitive lipase. This is present in your fatty tissues. So what does this do is it will break your triglycerides and your diglycerides. It will help them to break down into monoglycerides, and mostly where they are present in your adipocytes. Okay. Then we have LCAT, lecithin cholesterol transferase. So as we said, it helps in esterification of cholesterol. So from cholesterols we form cholesterol esters. And a second thing is it helps to mature. It helps in to, because now they are densely packed. So what we form are the mature HDLs in these. So LCAT is associated with HDL. Then LPL, that is a lipoprotein lipase. So this enzyme is present in your capillaries, the walls of your capillaries. It is where this enzyme is present. And what does this do is it will break down the triglycerides into your fatty acids and the glycerin. So we know that triglyceride is basically formed of glycerin plus 3 molecules of fatty acids. So it is going to break down into those. Okay. Then we have another one, that is CETP, that is cholesterol ester transfer protein. So as the name suggests, it helps in transfer. So this enzyme is present in your liver. It is more concerned with HDL. So what does it do is it helps to exchange the esters, the cholesterol esters which are present in your HDL. These are exchanged for triglycerides which are present in your VLDL. So this helps in exchange of these, and ultimately these cholesterols will be taken to the liver, the typical work of HDL, right? Then there is also a thing called PCSK9. So this is basically a protease. What does this do is that it causes LDL receptors degeneration. So when there won't be any receptors to take up these LDL, the serum level is going to increase of these LDLs, and that is why in our treatment purposes we have these PSK9 inhibitors are present, which we give as a pharmaceutical agents, right? Which tend to decrease the serum LDL levels. So that was a kind of applied for this. Okay, now let's study a bit about A beta lipoproteinemias. So this is another applied related to this. Oh, such a long word, right? Now, So as the name suggests, so A beta lipoproteinemia, there is absence of these apolipoproteins. So when these apolipoproteins are absent, what does it do? So there's no apolipoprotein present, so there won't be any your no chylomicrons will be there in your body, no VLDL, no LDL, nothing like. So very low levels of all of this will be present in your body. So why does this happen? Is because of so this occurs because of a gene which is MTP, that is microsomal triglyceride transfer protein. So this the gene microsomal triglyceride transfer protein, this gene, it is defective in these patients, and it is an autosomal recessive disorder. Now, in these patients, what will happen is that early on there will be signs of like steatorrhea, abdominal distension, fat malabsorption. These symptoms will be there, right? Early on, so signs of fat malabsorption, and later on there will be development because you are not getting enough nutrient, because fat is again an essential part, so you are getting, there will be developmental delay. Okay, then a patient may develop myopathies, because now your muscles are doing all the work. uh, Myopathy can occur. Then you can have ataxias or spinal degeneration. So lots of things could happen in this. How do we diagnose this? So uh, what we what we have is cholesterol level will be very low when you will do your the blood test of these patients. So cholesterol level will be less than 50 milligrams per deciliter. It is pretty low level. Okay, then there won't be or you can say low or zero levels of VLDL, LDL. So these all uh, mm, will be low or even zero, right? Then your vitamin E level will be low, fat malabsorption, and then so there will also be acanthocytes present. Now, what are these acanthocytes? So acanthocytes are basically the spur cells. So these have those projections. The cytoplasmic projections are there, and these are also called spur cells. And these are present in hereditary beta lipoproteinemia, and the disease name, to be precise, is Besson-Consberg's disease syndrome, you can say. Okay, now this these acanthocytes, they are also present in other conditions. Just to revise, so these are also present in hemolytic diseases, and then in your myelodysplastic syndromes, patients after splenectomy, then renal patients, patients of glomerulonephritis, right? So it will be present in these patients. The acanthocytes is just like something extra, right? Okay, then if you look at the these enterocytes on biopsy, there will be lots of lipids. So there will be lipid accumulation in the enterocytes. Now, because these are not being absorbed now, so lots of lipid accumulation will be seen on biopsy. Okay, so that's it. Now, what do we do for these patients? Okay, so I was talking about vitamin E now. So because this vitamin E level is low, that is so patient will have symptoms of these ataxias, weakness, and hemolysis. So ठीक है, so ataxia was because of low vitamin E, right? And hemolysis, again, that is why there was occurring acanthocytes, no? So this was again contributed by this only. And then vitamin A deficiency will lead to poor vision and those symptoms as well. Okay. Now, how do we one was this acanthocytes were low levels of vitamin E causing hemolysis, and second is that RBC's membrane, they also have lipid. Now those lipid is not there, right, abnormal, so it can lead to abnormal again formation of these acanthocytes, right. Now how do we treat is that first of all we will give vitamin E to these patients, and secondly we will cut down the long chain fatty acid consumption in these patients. Okay, so that was just a quick review of A beta lipoproteinemias. Okay, we know that the fatty acids and triacylglycerols, uh, so we have these fatty acids and triacylglycerols. What do these are the storage form. So these are stored in your adipocytes, and whenever energy is required, so these undergo beta oxidation and helps in formation of ATP. Okay, but also to remember that this whole process, it is also regulated by an important hormone called important enzyme called hormone sensitive lipase. So this hormone sensitive lipase, this enzyme helps to regulate this energy production by from these fatty acids and triacylglycerol. Okay. Now there is another topic, that is hypertriglyceridemias, which is associated with this. So hypertriglyceridemia, when the triglyceride levels, they are high more than 150 milligram per deciliter, that is said to be a state of hypertriglyceridemia. Okay. Now the causes, so there could be hereditary, like when you're this the enzyme hormone and the lipoprotein lipases. Okay, so if those are absent, so when your enzyme lipoprotein lipase is absent congenitally, so that could be a cause of hereditary. Then acquired, we have obesity, patient on alcohol, so too much alcohol, a chronic alcoholic is uh, uses an important mm, cause of hypertriglyceridemia. Then patients having liver disease, Cushing syndrome, nephrotic, so there are these conditions which cause the triglyceride. Even pregnancy is a state where your triglyceride levels, they do rise up. Then the drugs, so we have beta blockers can increase there. Then hydrochlorothiazides, patient having high dose of diuretic use, and some antipsychotics as well. These can cause increase in the triglyceride levels. So what is the significance of this is that when the increase in the triglyceride levels increases your risk of cardiovascular diseases, right. Now if we talk about the laboratory values, so if we have 150 to 199, that is said to be borderline or levels of triglyceride in your blood. If it is 200 to 499, it is high, or you can say moderate hypertriglyceridemias. And when it is more than 500 milligram per deciliter, it is very high, or you can say severe hypertriglyceridemias. Now, so whenever we do these triglyceride level monitoring, so we have to check for the cardiovascular risk score. Okay, and according to that also the treatment is there. So whenever there is a higher the score, that will of course tell you that we have to start statins, right. Now when we have this 200 to 400 range, that is moderate hypertriglyceridemia, so as we said, we can call it as a moderate hypertriglyceridemia, and this could be named as severe hypertriglyceridemias. Moderate one, first of all, of course, for the treatment purposes, we have to do the it will be applicable to all. So lifestyle changes has to be done if there is any associated conditions, like as we said, you know if there's some hepatic problem or Cushing's or something like that, so those associated conditions have to be treated. And also you have to avoid the medications like beta blockers. OCPs can also increase the lipid levels, right? Then antipsychotics, high dose diuretics, so all those things have to be stopped. So that is mostly what we do in the moderate hypertriglyceridemias. In severe hypertriglyceridemias, apart from that, you need to start statins to lower down the level. Of course, a low fat diet, and again those lifestyle modifications, go for walk, avoid sedentary lifestyle, quit alcohol use, okay, those things. And then we could also start omega 3 fatty acids. So the what is the role of these omega 3 fatty acids is that it will decrease the risk of pancreatitis, okay. And then we can also start fibrates in these patients because they have such high levels of triglycerides. So this omega 3 fatty acid, it is a essential fatty acid which we get from the nuts, seeds, okay. And what is its role is that it is anticoagulant. And what does it do is that it will replace the arachidonic acid. So it will decrease the thromboxane formation and thus decreases the platelet aggregation, therefore reduces the cardiovascular risk. So cardiovascular disease risk is reduced because of this use of omega 3 fatty acids. We also have another essential fatty acid which is called omega 6. This omega 6 is basically linolenic acid. It is present in your soya bean, the seed oil, cereals. So what does it do is that it is an arachidonic acid metabolite. So it will form leukotrienes, prostaglandins, and it increases the risk of cardiovascular disease. There should be a balance in between the use of omega 6 fatty acids, right? So that's about it. Thank you.
Thank you very much for listening. Let's keep on learning together.